In this next episode, we're about to talk about a syndrome that is impacting millions of women worldwide, but is still misdiagnosed in the exam room every single day. We're actually going to spend the next few minutes talking about PCOS, or Polycystic Ovarian Syndrome. Now, I have a very deep personal connection to this particular diagnosis. It is actually the diagnosis that led me to this entire field of holistic, integrative, and functional medicine. Back in my 20s, I was actually getting sicker and sicker as the years went by and experiencing all kinds of strange symptoms, everything from acne to hair loss, weird weight gain, and ultimately just achy, not being able to think clearly, and honestly, just a shadow version of who I originally was. It took a lot of coaxing for me to get into the doctor's office, but when I finally did, no one could diagnose me. Now, that was over 25 years ago, and as we sit today in our clinics at Whole Plus, unfortunately, it's the story that many of you tell us as well. The story of having symptoms that no one can put together, being told that you don't have PCOS because you don't have cysts on your ovaries, and nothing could be further from the truth. I could probably spend the entire episode telling you patient stories and how they were told they would never get pregnant, that there was nothing wrong with them, that they were simply anxious or depressed, and they needed to take a particular medication. And at the end of that story, they left our clinics with a diagnosis of PCOS. So, needless to say, this is a really important topic and one that I feel strongly we all need to understand and start to peel the layers back a little bit more easily. Now, when we look at the hard stats, right, when we just go to the literature and we look at, what is the rate of PCOS? At first, it's like, why is she making such a big deal about this? 1 in 10 women are diagnosed with PCOS. But here's the trick. Almost 70% of women go undiagnosed when it comes to PCOS. So while 1 in 10 maybe get the official diagnosis, we have a huge population, millions of women across the world who walk around not knowing that this is actually what's happening with their bodies. The misdiagnosis of PCOS is rooted in a number of different issues. First of all, PCOS was originally thought of as a purely GYN issue, an issue that comes up if you're trying to get pregnant, but is not related to anything else. And this is a problem we have in medicine in general, right? Where we don't understand that everything is interconnected and a hormone doesn't live in isolation, but actually interacts with other hormones. Now, traditionally, the diagnosis of PCOS was established by something called the Rotterdam criteria. The Rotterdam criteria was established by different physician groups and essentially said you had to have 2 of 3 particular characteristics to have a diagnosis of PCOS. One of them was that you had cysts on your ovaries. That's kind of a no-brainer. The second one was that you had an overproduction of something called androgens. Now, androgens are those hormones like DHT, free testosterone, DHEAS. These are the hormones that we traditionally associate with something like PCOS. And then the third was that you were having an issue getting your periods or anovulation, where you were skipping periods or not getting a period. And if you had 2 of those 3, then yes, you got the check mark for you've got PCOS. Unfortunately, the Rotterdam criteria have fallen short, and researchers and clinicians today both are actually in agreement that we need to find a better way. For example, in this particular study, this is from 2024, so recent, right? Evidence-based, common standardized guidelines for PCOS diagnosis and treatment are urgently needed. There is a problem understanding how women's health is getting impacted by this disease, and that's in a study as recent as just a few months ago. So we have a lot to learn when it comes to PCOS, and we have a lot to dig into. And we need to start widening our ability to diagnose this disease. And that's what we're going to talk about a little bit here today. And hopefully it's going to be helpful for you or for somebody that you love. When we think about PCOS, what most of the research, and I'll quote some of it for you shortly, but what most of the research seems to be pointing to is that PCOS is actually an autoimmune disease. And not just an autoimmune disease, it's a disease of your metabolic health. Your metabolic health is closely tied to what is happening with PCOS, and the roots of it go all the way back to your prenatal environment. I want you guys to think about that for a second. This is not your fault. In fact, today, even getting ready for this shoot, the woman doing my hair said, "Wait, what are you talking about? You're talking about PCOS? What do we do about it? I have PCOS." I feel like I can't go anywhere without having a conversation about this disorder because there's just so much confusion around it. But PCOS at the end of the day needs to be rethought and re-diagnosed in a much different framework. Let's look at what the research is starting to say. And I feel bad for so many of you out there struggling to get answers because this is such new research. And what happens with research is it often doesn't translate into the exam room for another decade or even sometimes for another 20 years. Here's another article. And I'm just going to read it. And I know that's probably boring, but I'm just going to read it out loud to you so that you understand what the research is saying. So this is from the Journal of Assisted Reproduction and Genetics. And essentially it's saying hyperandrogenism. Remember, that's the overproduction of those hormones that I was talking about, which was a part of the initial Rotterdam criteria. Hyperandrogenism causes insulin resistance and hyperglycemia, high blood sugar. And then that in turn leads to, and I'm going to use a lot of big words, but these are the things we dig into in practice day in and day out. It leads to oxidative stress, which is the ability of your cells to withstand the environment, other things that they're getting exposed to. But hyperandrogenism leads to more oxidative stress. It leads to belly fat and abdominal adiposity, and it leads to, and here's the big word, inflammation. And over time, those particular very functional medicine ideas, right, of inflammation, oxidative stress, belly fat, all of these things lead to disease. So there's a link, for example, between PCOS and many different diseases, including mental health disorders, cardiovascular disorders, autoimmune disease, having additional autoimmune disease, and of course, cancer. It's all connected. It's all linked up together. So when we look at the research and when we look in the exam room and when we look at traditionally what's been happening, we know that there has to be a new way to diagnose and understand PCOS. And simply using the Rotterdam criteria is not enough. And being told that you don't have cysts on your ovaries, therefore you don't have PCOS, is not the answer moving forward. Let's dig a little bit now into what we do need to do to get a better understanding of PCOS. When we look critically at PCOS statistics and we understand that it is very underdiagnosed and that so many women today are walking around with PCOS and are unaware of it, even though the stats have risen and they say 1 in 10 women today, maybe 1 in 20, have a true in the exam room diagnosis of PCOS, we need to understand a little bit better about why the rates of PCOS are increasing. I get asked this all the time. What's happening? Why are we seeing so much PCOS? Is it simply because we're more aware of it? And the answer is no. Here is what's happening in the exam room and also in research, what we're actually seeing day in and day out. PCOS is increasing for a number of reasons. When I turn to the research, it's fascinating. It's talking about the prenatal environment and how the prenatal environment, if, for example, your mom had high androgens or high insulin, you're predisposed to PCOS when you hit puberty. But here's the even more interesting piece of the puzzle. Prescription medication usage is tied to the development of PCOS. They are finding that antidepressants, anti-anxiety medications, anti-seizure medications are all linked to the development of PCOS because they are changing the prenatal environment that maybe you or your child or your loved one was exposed to right from conception. This is mind-blowing to me, right? Because for so long, it's like, oh, we're stressed or we're eating bad food or, we're doing all these other behaviors and that's why we have PCOS. But it's winding all the way back to what is happening in your mother's environment. And that's just the start. As those androgens continue to build and you're exposed to androgens, not just prenatally, but now as you go through life and you get them from processed food, from the environment. Again, we've got studies talking about how BPA, endocrine disruptors, phthalates increase the amount of androgens circulating in the bloodstream. We now need to think about this idea of the cumulative load, right? I've talked about it in reference to other conditions and other diseases. I talk to patients about it all the time. And I think one of the biggest challenges we're having in medicine, and that's why this holistic approach I think is so important, is that oftentimes it's not a singular hit that is causing a singular problem. It is a cumulative load that eventually is leading people down a particular path. And same is true for PCOS. So we've talked about the prenatal environment. We've talked about toxins exposed prenatally, androgens exposed prenatally, high cortisol if your mom was stressed, or if that stress continued through your childhood home, and as you entered puberty, you're more predisposed to PCOS. We've talked about medication usage, and one of the things we know for sure is that the prescription medication usage amongst all of us has gone up over the last 50 years. Young children today are put on many antibiotics, right? They're put on asthma medications. They're put on ADD and ADHD medications. All of these are changing the microbiology and the environment of the cell, and in turn, making the body more androgenic. We miss out on the opportunity to catch this because we don't check these things in childhood, right? We might check some of these numbers in a woman trying to get pregnant. And we can start to understand if someone's got a very high AMH, for example, or the high DHT or the high free testosterone. Sure, they're predisposed to PCOS, but we're not checking it in children before they hit puberty so that we can prep them to maybe avoid a PCOS journey. Then we enter puberty, and into puberty we go, and there are all kinds of challenges once we hit puberty. But what we are seeing now finally in puberty is the overexpression of these androgens. And they look different. They look like severe acne. They can look like body hair in places where we don't expect it. They can look like hair loss. But here are some of the other manifestations that we are missing, even in our teens. PCOS is associated with mood disorders. We have studies again that show how the androgens and the cortisol in turn work together to trigger things like depression, bipolar disease, and severe anxiety. We even know that it's connected to ADD and ADHD. And if you have a child with ADD or ADHD, I challenge you to observe them, watch them, see if their focus is different, especially in your girls. It's a little bit more easy to catch. If their focus is different at different points in their cycle. And I bet your answer is going to be yes. I see that right here in our own home. That again, the 2 weeks where estrogen is higher and those androgens can't be overexpressed, we see better focus. But the second 2 weeks, especially as the cycle approaches and those androgens are allowed to overexpress, focus and concentration weakens. So again, there are all these different manifestations of PCOS, and there are all these different reasons why PCOS has become the epidemic that it is today. We have to acknowledge that the environment has changed. Toxins and your toxic load has increased. The prenatal environment has changed. And then for our teens and for our young women in their 20s, talk about stress and cortisol, it's at a completely different level than it was even 50 years ago. We now have the added stress of connectivity and blue light that actually triggers an inflammatory load in the body. And when we take that inflammatory load and we combine it with all the hormones and all the environmental toxins and all the epigenetic changes, that's why PCOS is an epidemic today. And unfortunately, our medical models have not caught up to what's actually happening to the chemistry in our bodies. So PCOS is rising. It is an epidemic, and it is something that we need to think differently about. And sticking to old-fashioned criteria, like the Rotterdam criteria, is no longer going to be sufficient. What we are going to have to do instead is screen for PCOS from early childhood through the history of our hormonal life, because it actually presents in different ways at different stages. So what does that mean tactically? Let's break that down for just a second. So hopefully you're taking notes, and hopefully you're saying, okay, I agree with you, but now what do I do, right? We need to make this tactical. Here's what we need to be thinking about. If we're going to change this conversation around PCOS, and we're going to succeed in diagnosing PCOS earlier and being able to be maybe more proactive around it and preventing stories like mine or so many of my patients, then we really need a holistic approach and a holistic diagnostic approach. We can also use the word a functional approach or an integrative approach. Bottom line, we need a new approach. So, what I would like to see happen is a couple of things, no matter where you are in your time span, right? Whether you're a mom taking care of a child, whether you're a young woman really trying to get pregnant, or you're just not feeling right, or whether you're in your 30s and 40s and you're noticing hormone changes associated with PCOS, or even if you're in menopause, because there is a version of PCOS for each of these stages. Let's first review the symptoms to make sure you know what to dial into. Typically, the most common, loud, speaker friendly symptoms are going to be the acne, right? The cystic acne that's typically on the jawline and usually on the neck and often on the back. High androgen symptom, you can't miss it. That one's super obvious. Symptom number 2 is the hair loss. That's the one that got me, and it's called androgenetic alopecia. And in that particular symptom, you're losing hair, but the way you lose hair is very unique, and that's where you can diagnose it differently from other forms of hair loss. When it's PCOS, androgenetic hair loss, here's what's actually happening. The hair is getting thinner and more brittle. It's not coming straight out. It actually gets thinner and more brittle, and it's almost like crunchy. You can hear like paper sort of crunching in your fingers when you go to rub it. And that is because the hair follicle is narrowing because of the androgen exposure. And over time, that hair then falls out. So hair loss is a symptom, but that particular type of hair loss, where the diameter of the hair thins, it falls over time, it's almost not noticeable until next thing you know, you have this wide gap or part that you've never had before. And that's exactly what happened to me when I was dealing with PCOS in my 20s. All right, those are two very obvious symptoms. The third is you're skipping periods or you're not getting a period. Another I would still put in maybe the more obvious bucket of PCOS. But let's talk about some of the other ones. Gaining weight excessively, especially around the abdomen. Belly fat is often a sign of PCOS. And here's why, especially if you're having some of the hormone issues that go with it. Because with PCOS, there is this issue as the androgens go up, the insulin goes up, and we store fat. And we typically will first see that fat storage right around the belly, maybe around the arms, maybe around the back. Those are classic hallmark places where PCOS fat storage occurs. So that's another way you can tell. Here's another symptom that we just talked about, but it's the rise and fall of your mood and emotions. If you are having extremes of depression or anxiety, especially as your cycle approaches, it's another sort of whisper, a soft sign that you may have PCOS. And I'm going to give you one more skin sign, and here's what that one is. If you've got this velvety texture to the back of your skin, that's called acanthosis nigricans. Fancy word, I know, I'm sorry. But that's actually a sign that you might be insulin resistant. And in turn, if it's coupled with hormone imbalances, you may have PCOS. So that's a way to dial into your body and get a sense of what's going on. Now, when we flip the switch a little bit and we talk about looking at it from the vantage point of other systems of medicine, right? If we're really going to take this holistic approach. In Chinese medicine, here's what they would actually say about PCOS. They didn't diagnose it as PCOS, right? But here's what they did do. They would talk about it as liver qi stagnation, meaning your liver, for whatever reason, is not able to do the work your hormones need it to do. So here's what you would see. You would see the dark circles right under the eye. If you stuck your tongue out and looked at it in the mirror, you would see that darkening, kind of that purplish sort of reflection of the tongue. That's liver qi stagnation. The other pattern of PCOS was actually a gut pattern, believe it or not. They had already connected the fact that the gut and the hormones are interconnected. And if we ignore that connection, then in turn, we're going to have issues with overall balance in the body. So the way you tell that this time, if your face was red or ruddy, or you were getting a lot of rashes, or you were itching a lot, and then your tongue had a coating, whether it was a white coating or a yellow coating, you again should be thinking about something like PCOS. So again, these are self-diagnostic tools that you can use. I would almost, take a second to check in with your body, look at your face. What's happening with your face? Do you have circles under the eyes? Do you have a coating to your tongue? Or is your tongue kind of that purplish color that we were just talking about? Do you have a lot of cystic acne, or is there acne on the neck? Do you have hair loss or something that we need to be thinking about there? Do you have other rashes on your skin or your back, your legs, your arms? All of these are a way to check in with your body before you even hit an exam room and start to understand that there is a connection between what your hormones are doing and those androgens, and maybe or maybe not your ability or your risk, I should say, for having PCOS. So that's a quick diagnostic test that you can do. Now, what we do in the exam room is a little bit different. If we are suspicious of a patient having PCOS, then there are a number of things that we actually want to look at once we've passed a physical exam. Here's where we really start to test. And I hope you guys have, this is a resource that you can use and even take into the exam room with you. But you should be testing, and I mentioned it a few times in this particular episode, we should be testing a DHT, an AMH, a free testosterone, a total testosterone, a DHEAS, and even a 17-hydroxypregnenolone. Why? These are all androgens. And again, in pulling the literature, they talk over and over again about how a high AMH is connected to having PCOS. So when we look at all the androgens together, that's how we make the decision. Simply looking at a total testosterone, and many of you have said this back to us in the exam rooms, that, well, my testosterone is fine, so I can't have PCOS. That is not enough. We have to look deeper. And that's just the androgen part of the conversation. Remember, PCOS is a metabolic autoimmune disease. So we have to check the metabolic markers too. And what I'm talking about here are things like a fasting insulin, your triglycerides, your lipids, even your blood pressure matters in this scenario because PCOS is impacted by your metabolic state, and your metabolic state is impacting PCOS. In a particular study looking at PCOS, they talked about something called advanced glycation end products. All right, big words again. What am I talking about? I'm talking about foods, behaviors, toxins, emotions that at the end of the day increase these molecules that are basically high sugar or high glucose molecules. And that's right, everything I just mentioned can cause that. So when we're thinking about PCOS, looking at the metabolic markers is just as important as looking at the hormonal markers. They're intertwined. Now, there's one more set of markers that we like to look at before we put the whole puzzle together, and that's looking at inflammation markers. So if you have a high CRP, a high SED rate, a high TGF alpha, a high interleukin 6, these are all inflammatory markers that clue us into the fact that you are dealing with something like PCOS, because it's not just a hormone, but it's the hormone symphony that ultimately impacts you at the end of the day. So the holistic approach, the functional approach to diagnosing PCOS involves looking at all the hormones, looking at all the androgens and their derivatives, looking at inflammation markers and understanding what those markers are, and then also looking deeply at all the different metabolic markers and putting that puzzle piece together. Because what was missing in those Rotterdam criteria is the fact that PCOS is a metabolic disease, is an inflammatory disease, and is a disease of oxidative stress influenced by the environment, toxins, prenatal environment, and so much more. As we dive deeply into PCOS and how to think about it and how do we reposition it in the exam room so many women don't walk around undiagnosed, there's one caveat that we're also not talking about today, but the research is evolving and we are seeing it partly in the exam room as well. One of the things that we understand about PCOS is that there's actually a different presentation of PCOS depending on your race. I'm going to say that again. Your race matters when it comes to what PCOS will look like. Caucasians have a different presentation of PCOS than South Asians. South Asians have a different presentation of PCOS than traditional Asians. And they have a different presentation of PCOS when compared to Hispanics or when compared to Blacks. And each of them have to be evaluated a little bit differently and honestly treated differently as well. Let me tell you what I mean here. In the Caucasian population, we actually do see what the Rotterdam criteria initially talked about. Skipping of cycles, more cysts on the ovaries, higher androgen levels. However, when it comes to the Southeast Asian population, those criteria often don't apply. And instead, many of those folks are actually dealing with more of the acne or the hair loss component of it. So checking their androgens becomes critical to understanding what's happening in their version of PCOS. When we talk about Hispanics and Blacks, we see a huge preponderance of the metabolic component of it. In fact, Blacks have actually higher triglyceride levels when it comes to their version of PCOS than maybe a Hispanic, Caucasian, or Southeast Asian patient. Blacks also have a higher level of blood pressure. They have more hypertension when it comes to PCOS, and they have more issues with weight. Whereas a Hispanic patient instead may have more problems with something called hirsutism, which is where you have a lot of body hair or facial hair or hair in places where you really don't want it. So there is a racial component to PCOS when it comes to presentation. And that's another reason why globally PCOS is often missed, because the initial research was done mainly on a Caucasian population, not really paying attention to many of these other races. In fact, when we look at India, for example, and people of Indian descent, which of course I am as well, there is some talk that the incidence of PCOS among Indian women may be closer to 70%. So if you're Indian and you're watching this particular episode, it's not if you have PCOS, it's more like you probably do have PCOS, and how do we treat it and how do we try to understand it? So again, there is a racial undertone when it comes to PCOS, and this is something that we do need to dive more deeply into as we move forward. Now, as we've talked about PCOS and talked about the diagnosis, conventional diagnosis, the holistic diagnosis, now we understand the racial component to this as well. We need to understand that it's looking different when it walks into the exam room. So some people may be walking in with new onset weight gain, and they can't explain that weight gain. They've got belly fat, they've got maybe more heaviness in general than they've ever experienced before. And that's why PCOS is not just a disorder of women trying to get pregnant. Again, there's the childhood version. If a child has high androgens and high insulin, you're going to see the distribution of fat exactly the way we've been describing it for somebody with high insulin. Fat around the belly, fat around the chest, fat in the back, fat in the arms. If a teen has this issue with metabolic syndrome, right? Maybe you're seeing somebody who is African American or a Hispanic teen is having issues with weight gain. We need to be thinking about PCOS because, again, that midsection weight gain is tied to this hormonal imbalance. Now, what often happens, people will sail through childhood and maybe through their teen years just fine. And they'll even get through their 20s okay and not realize that they're having an issue with PCOS until they try to get pregnant. And then they go on an infertility journey that can be devastating and heart-wrenching, whereas at the end of the day, this was a metabolic issue. And it's really about the insulin and the blood sugar. And if they could correct that and those N-glycation products, then in turn, they would improve their hormone profile. But sometimes people sail through that too, and they hit perimenopause and menopause, but they actually have PCOS, so they have a PCOS version of this. Let me explain. When you hit perimenopause and menopause and estrogen levels decline, guess what happens if you have undiagnosed PCOS? Your androgens are allowed to overexpress themselves. And remember, high androgens, high insulin, it means two things for a woman in perimenopause and menopause. It means that now suddenly they're going through a second puberty. They're like, what just happened? They're getting acne. They're experiencing hair loss. Many women, as they go further into menopause, will get that classic male pattern baldness because they're having overexpression of androgens from undiagnosed PCOS. They also are gaining weight much more rapidly than their counterparts. If you take a PCOS woman and a non-PCOS woman and put them both through perimenopause and menopause, those with PCOS are going to struggle with weight gain and belly fat much more dramatically than those that don't have it. Because again, remember, those androgens are going up because estrogen is going down. Insulin is being overexpressed, or we're having an issue with hyperinsulinemia. And that in turn makes weight loss so difficult. And women in turn starve, overexercise, do everything they can do, but don't seem to see a difference. So understanding the racial undertones and how that's presenting in each of these cases of PCOS is so important, and how the metabolic, the hormonal, and the inflammatory part work together is critical in putting the whole puzzle together for any particular patient so that they are not just having success hormonally, but they're having success with their overall health. So now that we understand that PCOS is a truly autoimmune metabolic syndrome, not a hormone disorder, we can actually build a holistic plan. And here's what's exciting and encouraging, that we can actually do something about all of this. And here's where we really need to start. Once we've done the right testing and the lab work and we can really nail the pattern, then we can build a protocol around it. And the fundamentals of that protocol, while they are nuanced for every particular patient, because personalization does matter, there are some general principles that work. And I'm so excited to share some of those with you. In all forms of PCOS, whether we are dealing just with the androgens, with the inflammation, or with the metabolic component, we have to start with the gut. The gut is ground zero of health, and managing that microbiome and helping those gut bacteria metabolize hormones, reduce inflammation, and even help regulate blood sugar is a win that allows the rest of your health to come back together. So when we're talking about the gut with PCOS, there's some basic rules that you guys have heard before, but I'm going to reiterate them because they're so important when it comes to this disorder. An anti-inflammatory diet, right? Bringing in lots of plant-based foods, clean foods, and when you have a choice, choosing real food over processed food wins every single time. We've talked about that toxic load and how it helps accumulate and drive the body towards this sort of high insulin, high androgen state. So the gut is the first place to start. If you don't know where to start, that's where we begin. And changing your diet helps and changes the microbiome, but also supporting the gut helps too. And this is where doing things like taking digestive enzymes that help you metabolize your fats better, adding in a probiotic that's broad spectrum and has things like lactobacillus, bifidobacteria, bacillus bacteria in it can help support the hormones. In addition to that, helping rebuild the integrity of that gut lining. I love using glutamine. Some people like collagen, but these are things that make a difference when it comes to PCOS. And sometimes, over time, if you just work on the gut, the body starts to repair itself and the hormone profile starts to get better as well. I can share my own story with this, right? A part of my journey was not knowing that I had a gluten issue. And the minute I took gluten out of my diet, it's almost like everything kind of fell into place. Why? Because the integrity of my gut lining was right where it needed to be. The bacteria got rebalanced and my hormones started to behave. And that's one way of bringing those androgens down. If we move on from the gut, the next place to go when we think about a holistic approach to PCOS is looking at the liver. The liver is ground zero for your health, and you want to make sure you're supporting the liver, cleaning the liver, just like you would clean a room in your house. The way to do that is increasing your consumption of leafy greens, herbs like parsley and cilantro and oregano, which help the liver to detox very naturally. And in addition to that, adding things like dandelion tea or taking something called milk thistle, which helps the liver to flush, clean, rinse and repeat, and do what it needs to do. We also know that the liver benefits when we reduce its chemical exposure. So again, back to the food we eat, but even thinking about substances like alcohol, medications, or even excessive supplementation. All of these are hard on the liver and make it difficult for the liver to do its job to move bad hormones out and really regulate blood sugar the way it needs to be. So the gut and liver are ground zero, and that's why those Chinese medicine and Ayurvedic medicine concepts of liver qi stagnation or excessive yang or too much pitta apply to something like PCOS. Now, moving on from the gut and liver, where would we go next? Well, once we're sure we've tackled that, then we have to decide. This is where the road may diverge a little bit. So if you have high androgens, our first response is to put you on an androgen blocker. There are some natural androgen blockers that work beautifully. Saw palmetto, for example, is one of my favorites. Inositol is another one that works beautifully to help bring that androgen load down. Or you may be someone who the metabolic component is the strongest and biggest component. And in that case, thinking through things like berberine, which regulates blood sugar, adding in a good probiotic that also helps both the gut and the blood sugar component of it. And here I'm talking about something called akkermansia, which we found is connected to how the body uses blood sugar. That's another way of helping and really beginning a holistic approach to PCOS. And then finally, if you have an inflammatory piece that really needs to be managed, then we love bringing in high-dose omega-3, curcumin, boswellia. These are things that we have seen work in practice. But sometimes you need a medication, and medications aren't bad. But what we don't want to do is the Band-Aid approach. That you've got PCOS, here's your birth control and your spironolactone, and boom, you're done. What we want to do instead is kind of build this plan so the body isn't necessarily always dependent on this particular prescription medication. So this is where we've prescribed as well spironolactone in very low doses, and we're able to get away with low doses because we've done all this other work. So you may only need 12.5 to 25, maybe 50 milligrams of spironolactone in this particular scenario if you have high androgens. We've done oral minoxidil to help with the hair loss, and it makes a difference. And then we've also done the medications like metformin and even, I'm going to say it, even GLP-1 medications, because they in turn help to regulate the blood sugar and the hyperinsulinemia that's associated with PCOS. And all of this is then in turn influencing weight gain, adiposity, hormone balance, fertility, mood, and so much more. So again, when you take this holistic approach, you're not band-aiding a myriad of different symptoms, right? When I went on my journey, I was handed an anxiety medication at one point, a depression medication at another point, a birth control pill. I was given spironolactone. That's actually the medication which I had a very bad reaction to, but it was a lot about just band-aiding every symptom. We want to flip the switch, really, when we think about how to care for our bodies and think about stacking and building it sequentially, starting with the gut, moving to the liver, moving to nutrients that optimize all the different hormones and all the different cells of our body, providing it with chi and energy that we need to actually reproduce and to maintain our hormonal cycle. And then from there, moving into understanding that we have to regulate blood sugar. And there are so many different ways to regulate it, but there are some natural remedies that work. But if it's not working, then we move on. And that's the point of Whole Plus, is that we have to move on sometime and move into medications that work, but we can microdose medications and we can use less of them for less period of time when we've done this work. So that's the holistic approach. Now, I've left one really critical piece out of this entire equation. And I did so on purpose because one other thing that we have to talk about that I've alluded to as we've talked about PCOS is the impact of cortisol and stress, right? Cortisol is the stress hormone. And as cortisol ramps up, right, should I be surprised that mine expressed itself after, years of med school and residency and night shifts and all that stuff? Probably not. But as cortisol ramps up and we go into high cortisol states, we overproduce androgens and we overproduce insulin, and the body goes into this metabolic mode of PCOS. So managing cortisol is really important too. And there are a number of different ways to do that. And I have so many episodes and videos where we talk about that. But in the context of PCOS, I want to remind you all to have a plan to bring your cortisol down. Because that hum of cortisol that's coming from the pituitary and the hypothalamus is influencing your hormones. So whether you do acupuncture or yoga or massage or you meditate or you go on a retreat or you sleep, whatever it is, you have to have a consistent plan to start to calm those cortisol levels down. And if you find yourself in a position like I was in my 20s where I didn't really have control, right? I had to do night shifts, I had to do residency. These were not optional. Then you have to have a recovery plan that really works hard on bringing the cortisol way down. And in that way, you are protecting your hormones, but ultimately, you're protecting your long-term health. Because every time these symptoms go unchecked, it's more inflammation, it's more metabolic disease, it's more hormone disruption. And even though you may check off the goal, hey, I got pregnant, hey, I lost weight, hey, my mental health issues are stable, it's not over until these things are balanced. So a holistic approach to PCOS serves you well through your decades and through your lifespan. And avoiding doing this work only leads to more heartache, more medications, more disease burden, and ultimately a you that's simply not you. If you've struggled with PCOS or you know someone who has, I hope this gave you clarity and hope. For more tools and resources, head over to wholeplus.co and don't forget to subscribe for weekly videos that put women's health first.